Good morning, everybody. For those of you in the room, I have muted your account. So if you need to speak, Helena, you'll have to unmute. I want to get rid of the background noise. So good morning, everyone. Welcome to Grand Rounds. It's a pleasure on a snowy Friday morning, finally, to have everyone here. So today we have the Jenny Show. We got Jenny Ma and Jenny Q, along with Dr. Phil Altamari. Dr. Altamari, for those of you who don't know, is a vitreoretinal surgeon who practices at a St. Michael's Hospital, but also an ocular oncologist at Princess Margaret Hospital. So he wears multiple hats, and he's an absolute expert in the area of ocular oncology as well as VR surgery. Most important, though, he is just an absolute gentleman. When you're a resident going through our program, it is just a pleasure to work with Dr. Altamari. He's the most patient and kind surgeon that you will meet. And he's the type of surgeon that I think all of us aspire to be, caring and dedicated to our patients, and the type of physician you want to send your family to. So it's really a pleasure to have Dr. Altamari here this morning, along with our residents, Jenny and Jenny. So I'll hand the floor to them. The mic in the room is muted, so if Dr. Altamari wants to say a couple of words, we'll just have him unmute. And we will get him a camera soon. We're working on that.
For me to start sharing my screen?
Yeah, we can't hear them right now. So yeah, Jenny, you go ahead.
Okay.
So Jenny is one of our final year residents.
Is that on presenter mode?
Yeah, you're good.
Okay, so if it's okay, I guess I'll start. My name is Jenny. I'm one of the PGY5s, and the case that I'll be presenting is a case of a peculiar fundus lesion. So many thanks to Dr. Altamari for all of his help in putting together this presentation, and also Dr. Krema as well, who saw this patient in the clinic. Okay, so I want to introduce everyone to Mrs. M. Mrs. M is a 71-year-old female, and she's presenting to the ophthalmology clinic with the main complaint of floaters in the right eye. So because this is an ocular oncology grand rounds, of course, she does have a past oncologic history, which we will go through. So in 2011, she was diagnosed with a mucinous adenocarcinoma of the ovary, and this was treated with optional debulking, and then importantly, she received adjuvant chemotherapy, so specifically carboplatin and Taxol, and she responded well to this and then was in remission. In 2017, she was also diagnosed with a DCIS of the right breast, and then she received mastectomy for this. And also in the interim, she had a BCC of her skin, which was excised. So 4 months prior to her presentation in the ophthalmology clinic, she was seeing her oncology team, and then they diagnosed her with metastasis to the adrenals, the lungs, and bone as well. So they arranged for a lung biopsy, and the features of the lung biopsy were consistent with an adenocarcinoma with mucinous features. They also did immunohistochemistry as well. So they saw markers on the lung specimen that were consistent with the mucinous adenocarcinoma, but they did note that there were some differences in the markers between those that were seen on the lung and then those that were seen on the ovary back in 2011. But regardless, they diagnosed her with metastatic disease and likely from an ovarian origin, given she had that history of the ovarian cancer. So again, they started her on chemotherapy and the same regimen that she was treated on prior with her ovarian cancer, so the carboplatin and the Taxol. Now, she received a couple of rounds of this chemotherapy. She was followed up by her oncology team, but unfortunately, they had noted that her metastatic lesions had progressed and she was unfortunately getting worse. So that's sort of the background of her systemic and oncologic history before she's coming in to see us in the ophthalmology clinic. And so she comes to the ophthalmology clinic and she's assessed by the team. And so as you can see, her vision's not too significantly different in both eyes. In the affected eye, it's 20/30, which isn't too bad. And then 20/20 in the other eye, She has no RAPD and pupils were completely normal. And in terms of the pressure, I mean, sort of on the higher end of normal, but nothing too significant or nothing really alarming here. They did the anterior segment exam, which was normal. And then they did the dilated exam. So this is where we see some abnormalities. In the left eye, it was completely normal, no picture of it shown. And then here in the right eye, you can see along the inferior arcade, there's this area of retinal hypopigmentation, or this patch of whitening. And then interspersed within it are these hemorrhages throughout. So with this abnormality, of course, we want to get additional imaging, and they did a B scan. So you can see that lesion actually has some height or some thickness to it. So at its max thickness, it was about 1.36 millimeters. It was about like medium reflectivity. A fundus autofluorescence was also done. So you can see there's this area of hypoautofluorescence, which corresponds to that lesion that we saw clinically. An IVFA was also done. So on the picture on the left, you can see the early phases, and then on the right are the late phases of the fluorescein angiography. So turning your attention to the left picture, you can see that there's telangiectasia of the retinal vessels, some tortuosity as well. And then especially in that patch or that area of retinal whitening, you can see that there's fluorescein blockage in that area. And then on the right side, you can see that there's also leakage from that area as well. So an OCT was also done, and you can see that this just confirms there is involvement of the retina in the inner retinal and most of the retinal layers. You see this delamination, loss of delamination of the retinal layers. And you can also see there appears to be some sort of cleavage plane between the inner retinal layer, so the ILM and probably the ganglion cell layer, and the edge or the border of that lesion. So again, this confirms that the lesion was intraretinal, and on the OCT, there is no obvious or apparent involvement of the choroid. So just to summarize what we know now and what the clinical picture is, we have this 71-year-old female. She has this extensive cancer history, history of this aggressive mucinous adenocarcinoma of the ovary, which was treated in the past successfully and for which she was in remission for. But then she presented with these new metastatic lesions throughout the body. And so the oncology team started her on her chemotherapy regimen, which means she is currently immunosuppressed, and now presents with this new retinal lesion in the right eye. So based on the clinical picture and the imaging and some of the imaging findings, the presumptive diagnosis of viral retinitis was made. So they did do a vitreous tap and sent it for a viral PCR, which did come back negative. But again, because she has that extensive cancer history, of course, some sort of malignant neoplastic process is of course very high on the differential. So pretty urgently, a retinal biopsy was obtained for her and was arranged. And the findings really helped to make this diagnosis. So we can see here H&E staining on the left, and on the right, there's PAS staining for mucin. Immunohistochemistry was also done, and this, again, really helped to narrow down what the diagnosis was. So if we remember, I had mentioned that the oncology team had also arranged for a biopsy of her lung lesions, and there were some differences in the markers on the lung versus the original markers in the ovary from 2011. And so with the immunohistochemistry and the pathology from the retinal biopsy, it turns out that the markers on the retina specimen actually matched those on the lungs. And again, these two did not match the ones in the ovary. So this helped to change her diagnosis to an invasive mucinous adenocarcinoma with retinal metastasis, but actually the primary lesion was coming from the lung. So the lung itself was the primary lesion and not the ovary. So it turns out she's had two primary lesions, one from the ovary in the past, and now this was one coming from the lung. So the lung wasn't a metastatic lesion as they had originally thought. And that's also why she wasn't responding to that chemotherapy of the carboplatin and the Taxol, which previously her ovarian cancer had responded to. So the oncology team changed the chemotherapy regimen so that it would target the lung adenocarcinoma more specifically. And here on this picture, we can see this is what the retinal metastatic lesion looked like before the change in the chemotherapy. And then 1 month afterwards, like around it, you can see the laser scars from the biopsy, but the lesion itself has actually regressed after this chemotherapy change. And in fact, her systemic metastatic lesions as well, which were previously getting worse on their carboplatin and the Taxol, had regressed as well with this new chemotherapy regimen. So now shifting gears to talking about retinal metastases. Retinal metastases are actually quite rare. They make up less than 1% of all intraocular metastases. And the reason for this is because of the hematogenious spread of the metastatic cancer cells. And so it's the anatomy of the retinal vasculature and arterial system that will dictate the predilection of where the tumor cells preferentially spread to. So as everyone knows, the choroid is very well vascularized, and so this becomes the preferred site for intraocular metastases, where structures like the retina or the optic nerve, they're supplied by mainly by the single central retinal artery, and so they're less commonly involved when this occurs. When the retina is involved, it's usually the inner retinal layers that are involved again. Likely it's because of the dissemination of the tumor cells through the central retinal artery. And again, because this is pretty rare, there are just a couple reports of this in the literature. They do describe different areas where the metastatic cells come from. So some of the common places include the breast for women, and then also the lungs are an important primary source, again, with the frequency of lung cancers that occur. And going downwards, the GI system is also an important primary source, for example, large intestine. And then ovarian cancers are also an important primary source. So for example, in this patient, initially it was thought that her metastatic lesions had originated from her ovarian adenocarcinoma. And of course, with melanoma and skin cancers, that becomes a common primary source for metastatic lesions. So when patients do have retinal metastases, how do they present? In terms of symptoms, pretty non-specific, blurred vision, floaters. I mean, it really doesn't help to narrow down the differential diagnosis at all. Patients present with these complaints all the time. So of course you need to do additional testing and finish the complete exam to really help hone your differential diagnosis and determine the etiology. So things that you might see on the fundus exam. This is actually a picture from a case report of another retinal metastatic lesion that came also from a lung mucinous adenocarcinoma. And you can see actually the image looks pretty similar to what we see in the patient when she initially presented. There's this white patch of retinal whitening or necrotic area, and then interspersed within it, you see these hemorrhages, and some of them sort of follow the vascular distribution within the retina. So again, these patients can present and often present with retinal hemorrhages, exudation, ischemia. Sometimes they might present with a retinal detachment, and rarely you might see a vitreous hemorrhage or some vitreous cells. So here's another picture where you can see this patch or area of retinal whitening that's distributed along the inferior arcade, and then interspersed throughout, you can see these hemorrhages as well. But in fact, this is actually a picture of a retinitis. So going through the literature, often these patients, when they presented, were initially misdiagnosed as a retinitis. And it's makes sense because a lot of these patients, when they present, they are often on some sort of chemotherapy or some sort of treatment for their systemic cancer or systemic metastatic disease. And so these patients are immunosuppressed because of the chemotherapy, which does make them prone to opportunistic infections. So in addition to the retinal metastases, retinitis is also high on the list. Another differential diagnosis for these sorts of lesions include some sort of vaso-occlusive disease or disorder. Again, these patients are often already diagnosed with malignancies, which might make them prone to more thrombotic issues or develop some sort of coagulopathy that could have maybe a similar sort of picture. And once you do see these sorts of lesions, of course, additional imaging is very important to help hone your diagnosis. So if we go back to some of the images that the patient had, we can see here, this is her IVFA, and there's some abnormal or atypical things here. With the superficial retinal vasculature, we can see that it's altered. She has telangiectasia, and again, the tortuosity of some of the vessels, which might make you more suspicious of some sort of malignant process going on. And then the OCT as well. So again, the picture on the left is her OCT from the patient herself. And then on the right, this is an OCT from that retinal metastases that was reported in the literature. So you can see some similarities between the morphology of the retina and the OCT images. There's, again, that delamination between the inner retinal layers, mostly like the ILM and the ganglion cell layer, and then the edge of the tumor. So you see the similarities between those. And then if we zoom in a little bit more to the patient's OCT and one of the other images that was taken, you can see some atypical findings here. So you see this sort of really fluffy material that's protruding out from the surface of the retina that extends into the vitreous. And this actually represents the vitreous seeding from the tumors. So again, this is another atypical finding that might point you more into the direction of a malignant or neoplastic process that's going on. And also in this zoomed in picture, it's working, but you can see a bit more about that the cleavage plane between the inner retinal layers and then probably what's the border of the tumor. Okay, so once patients are diagnosed with a retinal metastasis, usually this indicates a pretty poor prognosis for them. By the time a retinal metastasis is seen and diagnosed, usually the patients already have diffuse dissemination to their other organs, and importantly, this includes the CNS. And this is why it portends such a poor prognosis. In fact, in a lot of the reports in the literature, once patients were diagnosed with a retinal metastasis, they often were treated for it, but not long after they did unfortunately pass away. And this just shows how poor of a prognosis it is when patients present in this way. And of course, there's different treatment options available for the retinal metastasis and usually for the concurrent other metastases throughout the body. It really depends on the patient's goals of care and the staging, again, what other organ systems might be involved by the time the retinal metastasis is diagnosed. It's really important to work with the oncology team, of course, to direct care and figure out the best treatment for this patient. Observation is always an option. Other options include things like chemotherapy or local radiation, and enucleation is an option as well, or some sort of combination of the above. Of course, again, working with the oncology team is really key to direct care. So just to round out the talk, for these sorts of patients, it's very important to maintain a very high index of suspicion. So going back to the basics and making sure that you take a thorough history. These patients often have some sort of oncologic history, so making sure you talk to them about what sort of cancers they've had in the past, the treatment options they've had for them, whether they're in remission, things like that. Doing complete and comprehensive physical exam is very important. And then specifically when you do the additional imaging, just keep your antennas up about any atypical or suspicious findings that might lead you to a diagnosis of a malignancy. So for example, the vitreous seeding for this patient that was seen on the OCT. And when you do have a suspicion of a malignant process, it's very important to order additional investigations, even if these might mean doing more invasive testing. So for this patient, initially, again, one of the presumptive diagnoses was a viral retinitis, but a malignant process was very high on the differential. So quite urgently, a retinal biopsy was arranged for her, which really helped to expedite the diagnosis. And then particularly in this patient, immunohistochemistry was very important because it helped to differentiate the fact that the primary had come from the lung and not the ovary. And this really helped to redirect her chemotherapy treatment to targeting the lung. And this helped her metastatic lesions regress, and they responded to the new chemotherapy regimen. So taking all of these together, this is what people or clinicians should be thinking about when they're assessing these very complex patients. Thank you.
Well,
Thank you, Jen. That was well done.
So
Was an
go
echo.
ahead. I got rid of your echo there.
Any questions?
So there's a question from Dr. Cates. Do you see retinal vessel telangiectasia in viral retinitis?
Not typically. It was an unusual picture. Even the retinal thickening is not consistent with the viral retinitis. But because of the part of the clinical appearance, the fact that she was immunocompromised, and the treatment for a viral retinitis was immediately done on the same day, it allows us to kind of triage things. And if we were to see a response, then that would basically change our management. But our threshold to go in and do a retinal biopsy was very, very low. The importance, so I hope that answers that question. It just made it a little safer for everybody. The importance of this case is that the landscape in oncology is, there's a lot more new therapies, especially immunotherapy, and they're improving a lot patient survival. And so now we're starting to see more of unusual cases that normally we wouldn't, such as retinal metastases, especially in the setting of cutaneous melanoma. So a rare event is now becoming less rare, and so our awareness of it should be a little bit more we should be more aware of it, that can be a possibility, especially in a case like this where you can actually triage. And there was a difference in outcome based upon whether this was a primary in the lung versus a primary in the ovary. So it really helps a lot in the overall patient management and outcome as well.
Yeah, that's a great point. That was going to be my question, actually. A retinal biopsy is no small feat. And in this case, it definitely changed the patient's systemic course and outcome. So I guess my question to you, Dr. Altamari, is, is the threshold for retinal biopsy changing when you see a patient with known systemic disease? Are you, would you consider biopsying any patient with retinal presumed Mets?
So on one aspect is our diagnostic imaging is really accelerated. It makes it a little bit easier to try to tease out what we're dealing with. Second, the team at Princess Margaret Hospital has an excellent cytology team. So it's very easy for us even to do in the office a needle biopsy and not have any fluid or any visible material and still get an excellent outcome. And then the third aspect is, even with retinal biopsy, there have been some, recent modification in technique that actually simplifies things a lot. And so, the threshold becomes lower because of that.
Bill, for us non-retina people, could you
I
just,
can't hear you, Alan, sorry.
for us non-retina people, could you just basically briefly describe what you do with the biopsy? How do you do it? And are there any situations where you would not want a biopsy, like with a viral condition? If you're worried about virus, could you spread the virus? Is there chances of spreading the tumor cells if you don't do the biopsy properly?
I'm not sure I got all of your questions, but with respect to the viral issue, the PCR that we get back is fairly quickly. So you'll know within a few days or less what the results are, and that will help triage which way you should go with your management. And it won't necessarily change the status of the eye. It can be done simply by paracentesis. It does not have to be done through a vitreous aspirate. The retinal biopsy, I actually did it in a very different way from what's traditionally been done. Traditionally, we cut the piece of retina and we take forceps and we extract the tissue. Here I was able to, yes, I bimanually cut the small piece, but I aspirated that whole piece into a cannula. So you preserve a lot more of that tissue and maintain more of the integrity of the morphology of it. And so that can help the pathologists and cytologists, in part because they always are concerned that they're getting small specimens from ophthalmology, and rightfully so for what we were dealing with. I don't know if I've answered all your question, Alan.
It does. I just wanted to basically know how you're doing the biopsy. I know we run into the same problem when we do a conjunctival biopsy or something like that, getting enough tissue.
Yeah, and with respect to spread, it's already a metastatic event, so we're not going to be modifying that. But let's say this was a primary tumor within the eye itself. If we cast aside retinoblastoma, we will not, most of the times, I haven't seen a case of it, facilitate the spread of it. In part, when we're dealing with respect, for example, with uveal melanoma, which is the most common adult cancer, it's more about the genetics of it that actually kind of predetermines that risk factor for spread. Whether or not you put in a needle or you take a piece of it, it's less a contributing factor. The cells have to be engineered and be ready to metastasize rather than the instrumentation that facilitates that. I mean, there are some little caveats. You can spread it within the tumor within the eye. Yes, that's a possibility. But to facilitate metastatic spread, I haven't seen that type of scenario, even though, again, these are rare events that I'm doing biopsies on and so forth. But as an example, the few endoresections of uveal melanomas that I've done, the few of them, none of them have had intraocular dissemination or external dissemination, from the wounds or anything like that. And in that situation, you're removing all of that cancer cells. I'm sure I'm missing some of them within that vitreous cavity. And there's potential even technically spread because I'm going on to bare sclera that you could have emissary vessels being a track for some of these cells to go. But the actual outcome will be predetermined by the genetics of it. Long-winded answer on my part.
Very good
you.
answer.
Jenny Ma, do you want to get your talk up? Maybe we can move to the second talk. Okay, we'll just give her a minute to set up there. You're good. Now you are muted, Jenny. You may want to just unmute yourself there.
Okay. I don't know. Okay. So I'm Jenny. I'm one of the PGY3s in the program. and I would like to thank Dr. Altomari for helping to put these slides together. Our next case is called To Grow or Not to Grow. That is the question. So this case starts with Mr. M. He is a 66-year-old gentleman who is asymptomatic and presents for a routine eye exam. So he has no significant past ocular history. And on past medical, he has hypertension and BPH, for which he takes printopril and tamsulosin. His vision is 20/20 in both eyes, and he has normal pressures in both eyes as well. So on anterior segment exam, you notice some scleral hyperpigmentation, which is suggestive of ocular melanocytosis upon lifting up the eyelids. And you also notice some mild hyperpigmentation of the iris of the right eye compared to the left. On fundus exam, there is a nasal juxtapapillary melanocytic lesion with orange pigment in the right eye. And on fundus autofluorescence, you notice that this lesion has a hyperautofluorescent signal corresponding to areas of orange pigment noted clinically and gravity-dependent patterns suggestive of subretinal fluid. So on OCT, there is hyperreflectivity in the nasal juxtapapillary area consistent with a choroidal melanocytic lesion. And there is also subretinal fluid, intraretinal fluid, and an altered RPE and choriocapillaris. The OCT of the left eye is normal. Next, on B scan, there is low internal reflectivity. And on the corresponding A scan, the first peak corresponds to the retina, the second peak to the choroid, suggestive of subretinal fluid that we noted previously, and the third peak corresponds to the sclera there. So measuring the distance between the second and third peak gives us the height of the lesion, which was 2.4 millimeters, and the height measured 7.4 by 8.2 millimeters. So this brings us to our first poll question, which is, what would you do next in the management of this patient? Would you observe with repeat fundus photos, fundus autofluorescence in OCT and B scan in 6 months? Would you do a transretinal biopsy of the lesion and then decide on treatment depending on what the biopsy shows? Do brachytherapy with adjuvant transpupillary thermotherapy? Move to brachytherapy with transretinal biopsy and adjuvant transpupillary thermotherapy, or do an enucleation?
We'll give that a second to run there, Jenny. All right, looks like you got a bit of a split, but no one went for immediate enucleation.
Okay. So we'll share the results. So most people selected transretinal biopsy of the lesion. So to help us answer this question, how do I close this? Oh, here. All right. So in this case, we went with D, but to help us decide what to do, we can look at both patient risk factors for developing uveal melanoma and risk factors for lesion growth. So in terms of patient risk factors, they include being an older aged individual from 50 to 70, having fair skin or iris color and being more sensitive to sunburning, the presence of multiple skin nevi or ocular melanocytosis or melanocytoma, having a family history of cutaneous or uveal melanoma, and the presence of certain germline mutations. Some symptoms which are suggestive of uveal melanoma include blurred or distorted vision, visual field deficits, photopsias, and heterochromia. To assess risk factors for growth, we can use the acronym to find small ocular melanoma using Helpful Hints Daily, which corresponds to a thickness of over 2 millimeters, having subretinal fluid present either clinically or on OCT. So even if the fluid is subclinical, it still presents a risk. The presence of symptoms like we talked about, the presence of orange pigment, having a margin of the lesion that is within 3 millimeters of the optic disc, the presence of ultrasonographic hollowness on B scan versus having a solid or flat lesion. The absence of a halo, whereby a halo is a circular band of depigmentation surrounding a pigmented choroidal nevus, and the absence of drusen. There are also some features on B scan which have been correlated with choroidal melanoma. So that's low to medium internal reflectivity, having a basal diameter over 7 millimeters or over 5 millimeters on fundus exam, and a thickness over 2 millimeters. Particularly for our case, the presence of ocular melanocytosis was quite significant. So an average individual's lifetime risk of uveal melanoma is 5 in 1 million, but with ocular or oculodermal melanocytosis, this increases quite significantly to 1 in 400. And these risk factors do come with a few caveats. So the first is that certain risk factors are stronger than others, and that is thickness, the presence of subretinal fluid, symptoms, and orange pigment. And subretinal fluid and orange pigment can suggest acuity. The absence of halo and absence of drusen are less significant as risk factors. So the presence of drusen can suggest a benign lesion, but this is not absolute. And lastly, the margin of the lesion and its proximity to the optic disc is no longer traditionally considered a risk factor. So these risk factors can subsequently be used to guide management. For lesions that displayed none of the previous risk factors, there was only a 3% chance of growth at 5 years. And so these lesions most likely represented benign nevi. They can be monitored twice in the first year and then annually thereafter if the lesion is stable. For those that display 1 to 2 risk factors, there's a 38% chance for growth. So they can be observed every 4 to 6 months, especially if the lesion is in a visually important location. However, for lesions with 3 or more risk factors, over 50% showed growth. So such lesions likely represent small choroidal melanomas, and early intervention and treatment should be considered, as they may occasionally lead to metastasis. So if you'll remember the previous risk factors, our patient actually had 7 of them, which is what led us to ultimately pursue brachytherapy with the biopsy as well. There is also a mole scoring system that has been developed to aid non-specialists in monitoring and making referral decisions about choroidal lesions without requiring additional imaging techniques such as ultrasound or OCT. So this acronym stands for having a mushroom shape, orange pigment, a large size, an enlarging tumor, and presence of subretinal fluid. So each of these features is given a score of 0, 1, or 2, depending on whether it is absent, borderline, or present. And these 5 features were selected with the aim of making moles a very sensitive scoring system. So adding all of our patients' risk factors up, he had a score of 7 as well. Then, based on the mole score, there's also some suggested management. So depending on whether the score is 0, 1 to 2, or at least 3, these lesions can be monitored in the community every 1 to 2 years for common nevi. For low risk and high risk nevi, a non-urgent referral can be made to a specialist. However, if the score is at least 3, then the lesion is probable melanoma. So an urgent referral to an ocular oncologist should be made to consider additional investigations and early treatment. And some previous studies have found this scoring system to be 99.8% sensitive for indicating malignancy in melanocytic choroidal tumors where the mole score is at least 3. So it's quite a useful tool for primary eye care providers to optimize the referral of these tumors to specialist care. And because it's designed to be a triaging tool, We ideally want a system with high sensitivity and are less worried about specificity. So after confirming malignancy, these tumors can be prognosticated with a fine needle aspiration biopsy prior to plaque placement. And this sample can be tested for a set of genes using either RNA or DNA. So RNA will give a gene expression profile, but this is quite sensitive. An RNA sample is quite sensitive to degradation. So samples need to be placed in dry ice right away. DNA has been less extensively studied, but is more convenient as the samples are less degradable and it's also OHIP covered. For purposes of this talk, we'll focus mainly on RNA. So RNA will give a gene expression profile, and based on this profile, uveal melanomas can be classified into 3 distinct molecular classes, with class 1A having a low metastatic risk, 1B having an intermediate risk, and 2 having a high metastatic risk. And gene expression profiling has been found to provide prognostic information that is more accurate than clinical, pathologic, or cytogenic factors. And currently, there are both RNA and DNA-based gene assays available commercially, and the RNA one has been validated to successfully classify over 97% of cases. So these are some genes that are included in the gene expression profile analysis. And certain genes are involved in stratifying tumors into either class 1 or 2. So nearly all uveal melanomas undergo an early mutation in the G protein receptor signaling pathway. And this mutation is involved in tumor initiation, but not directly correlated with prognosis. After this early event, our first fork is with the BAP1 mutation. So if a tumor is BAP1 positive, then it is in class 2. And if it's negative, then it belongs to class 1. And this risk classification does not change in the tumor's lifespan. After BAP1, our next fork is with the PRAME mutation, which is an epigenetic factor. So PRAME negative melanomas have a low metastatic risk over here, and PRAME positive mutations have an intermediate metastatic risk. Then, based on the metastasis risk, different intensities of surveillance can be undertaken with liver imaging and monitoring of liver enzymes either annually, every 6 months, or every 3 months, depending on the risk level. However, if the uveal melanoma were to metastasize, there is unfortunately a very poor prognosis with a 1-year overall survival of only around 50%. And currently, there are limited systemic treatments that have a proven survival benefit. 2 systemic therapies with promising results currently in phase 2 and 3 clinical trials are tebentafusp and a combination of darovasertib and crizotinib. So first for tebentafusp, this is a bispecific protein that redirects T cells to target glycoprotein 100 positive cells and is designed for use in HLA-A genotype positive patients with metastatic uveal melanoma. It's currently in phase 3 trials and showed an overall survival at 1 year of 73% versus 53% in the control group, which was statistically significant. And the most common treatment-related adverse events included rash, pyrexia, and pruritus. So on these Kaplan-Meier curves, you can see tebentafusp showed a benefit compared to the control in both overall survival and progression-free survival at 1 year with a lower hazard ratio for both death and disease progression. Another therapy with promising results on the horizon is combined darovasertib and crizotinib, which is currently in phase 2 trials and is designed for use in HLA-A negative patients. So these are a combination of protein C inhibitors and MEK inhibitors. And some early results show an overall response rate of 45%, whereas historical response rates of other therapies have ranged from 0 to 5%. There's a disease control rate of around 90% and a median progression-free survival of around 7 months. So our take-home points from this case include to remember to look under the eyelid for ocular melanocytosis, as this significantly increases someone's risk of having uveal melanoma. The risk for growth can be assessed with the acronym to find small ocular melanoma using helpful hints daily, and referral decisions can be aided with the mole scoring system. Early intervention and treatment should be considered for high-risk lesions. A biopsy sample can be used for gene expression profiling to prognosticate the metastasis risk. And lastly, some new therapies which have shown promising early results include tebentafusp and combined darovasertib and crizotinib. And these are references. Thank you.
Well done.
Excellent, thank you. So there's a comment about heterochromia in the setting of uveal melanoma. Is it the affected eye or the unaffected eye that is hyper or hypopigmented?
It's the affected eye.
The affected eye, it's hyper or hypo?
I missed what you said.
Is it hyperpigmented or hypopigmented, the affected eye?
Hyper.
Hyper.
So there's increased pigmentation through all uveal layers.
Thank you. I have a question actually. You know, we don't see as many uveal melanomas in our general clinics as you see, but we see a lot of people with nevus. And I guess my question is, you know, with the preponderance of fundus autofluorescence now and AI being so hot, you know, is there any movement to, you know, AI and fundus autofluorescence sort of making this easier for us in terms of screening?
So the mole study, or some of the people behind the moles stratification, are looking at that to make it easier for, you know, someone in the public to be triaged efficiently at, you know, without burdening the system itself. So multimodal imaging is amenable to that, not just the fundus autofluorescence, simply because orange pigment and fluid by itself can also be seen in another situation, even a choroidal nevus or a non-melanocytic tumor per se, because it reflects more the RPE function at that level under those circumstances. So I think it'll be more about multimodal imaging with AI rather than just one single modality with AI. But certainly that can expedite, and that was the point for that question, is that in the first case, we did the biopsy for diagnosis, but in this case, our clinical assessment is just as high accuracy as a biopsy. And so there was not a need for a biopsy for diagnosis, but the purpose of the biopsy is to be more predictive of at what risk that patient is at from metastasis. And in lieu of that, there are now some newer therapies, or at least at the edge of becoming more clinically amenable or accessible. Then you want to be able to have the high-risk patient to be treated early with some of these newer therapies that will be coming down the road.
Got it. Thank you. There's no further questions in the chat, so I do want to thank you, Dr. Altamari and Jenny Q and Jenny Ma, for your wonderful presentations this morning and the review of ocular oncology. It's always nice to get a little refresher. You know, this is all the weird and wonderful stuff that might come into our offices once a year, and those patients scare us significantly. So we're very fortunate to have people like yourself and Dr. Crema and Dr. Weisbrod and the whole team at Princess Margaret as a wonderful resource for our department. So thank you for the presentation and the hard work you do all year round.
Thank you. And thanks to Jenny and Jenny.
Now for the audience, there is a evaluation. You'll see the link on your way out as we end the meeting. You fill the evaluation link out for your CME credits, please. Thank you.
Great presentations, guys.
Thank you. Any questions from the audience here? You guys
Well,
want
I
to
got
take
a quick one.
what's the next part?
The first poll went up about, for the second case, about doing all these tests, whether you follow up in 6 months. One thing that wasn't on the list was a systemic workup. Isn't that important in order to get grading?
The likelihood of being able to pick up at presentation in the ocular oncology office anything systemic is extremely low. And so a lot of the workup is more geared to having the patient ready to go to the OR from an anesthetic standpoint. So a lot of the traditional things of a chest X-ray liver function test are not very predictive at all. What's more important is more in follow-up post-treatment is yearly imaging of your liver, because the number one site where this likes to go to 9 times out of 10 is the liver. And so that's what's currently recommended. But things are changing. And so there is quite a lot of research looking into just looking at a serum sample. Can you identify a tumor DNA? When that becomes available, it really will boil down to just doing a blood test to kind of determine if you actually already have uveal melanoma DNA in the blood because of what's going on in the eye itself. So there will be other strategy, but with the current makeup of doing a full MRI, PET scan, and anything else, it won't change the outcome or the management of it. So it's not a very cost-efficient way of doing things right now.
How urgent is it to get that biopsy once diagnosed?
I'm sorry?
How urgent is it to get the biopsy done?
For the intraocular biopsy, you mean?
Yeah.
So we to our patients, we recommend that. It does become a personal choice, in part because right now it's more for prognosis. And there are some patients that elect not to want to know how high risk or low risk they are. But as the therapies become much more amenable with much better survival and so forth, that will become a lot more required. And patients will be interested because something can be done about it in prolonging survival, as mentioned with tebentafusp. But even some of the PKC inhibitors are starting to show some benefit. It just has to be demonstrated for the longer term. So as our treatment for metastasis improves, then it becomes a greater need to verify that with a biopsy, but it does not have to be an intraocular biopsy. It could be a liquid biopsy by just taking a blood sample. So it doesn't necessarily mean I have to work more.
Thanks for updating us on all these new changes happening in ocular oncology, Phil.
Appreciate it.
Very interesting.
My pleasure.
Okay, well, there's no further questions, so I'll bring the Zoom to an end and enjoy the resident teaching this morning, guys. Dr. Rosemary, thank you again.
Thank you.
Bye.